So wonderful to have you all. Let's keep this as a freewheeling question answer session. Any topic, medicine, homeopathy, organon, materia, repertory, anything, whatever I know, I will answer to the best of my ability. You can put your question uh, in the chat box, either in the YouTube or in Insta. I'm there on both of these media. Please feel free to put your questions. Do we have a list of some questions that have come beforehand, Dr. Keyur? So we set the ball rolling. Scope of homeopathy in autoimmune diseases? Well, yes. What is the scope in autoimmune diseases? So, to the best of my knowledge, homeopathic medicines are immune modulators. They modulate our immune system and bring it back within its normality, whether it is a hypersensitive reaction or whether it is immunocompromised situation. Autoimmune diseases, when we talk of autoimmune diseases, we will better to talk in terms of remission rather than in terms of cure. That is number one. Number two, I will talk in terms of quality of life. This is very critical. In the modern understanding in contemporary medicine, what we are now talking about, whether it is type 1 diabetes, whether it is rheumatoid arthritis, whether it is ankylosing spondylitis, we talk of quality of life. The focus of health is now shifting to what is called as life quality, how functional you are regardless of your parameters. You may have a higher CRP, you may have a high RA factor, but if you are pain free, you feel good, you feel energetic and healthy and looking forward to life, then you have got the quality of life. Now, each disease affects a different parameter of life quality. Some can be disabling, some uh, a disease like rheumatoid arthritis can be very disabling. The ability to function is a problem. So, if you have a high CRP, but you are functioning well, your spirits are good, then we have achieved our goal. So, homeopaths, our community needs to realign the focus, especially when it comes down to an autoimmune diseases where we talk of quality of life. In fact, in diabetes, the goals are redefined. Earlier, they used to talk of three parameters: fasting sugar, post lunch sugar, and HbA1c. Today, they talk of five parameters, and that is very interesting for a homeopath. Why? So, let me talk about this. This is an opportunity to even educate about diabetes, upon which I've worked quite extensively and quite deeply. So they talk of three traditional parameters: fasting blood sugar, post lunch blood sugar, and HbA1c. These are three. They added two more. What are those two more? One is quality of life, and the other one is glycemic variability. I will explain this a little bit more. uh, the range of fluctuation of your sugar is called glycemic variability. These five things together constitute what is called as a diabetic pentad. And you are going to look for five things if your medicine can affect. For example, in a type 1 patient and even in a type 2 patient, if your medicine is able to bring down this range of fluctuation, then you have achieved a big milestone. Why? Because the range of fluctuation of sugar is directly proportional to the complication, the end organ damage. And then comes the quality of life. Same way for rheumatoid arthritis, we are going to talk of quality of life. Same way we are going to talk of in ankylosing spondylitis, we are going to talk of quality of life. In Sjogren's, we are again going to talk about quality of life. I have started having a much bigger canvas when I treat autoimmune diseases, when I monitor autoimmune diseases. And they need to be monitored normally over a period of long years. Then you are able to acknowledge and even understand what change, what we are able to offer our patients. I hope that clarifies quite a bit of it. The question I answered what best I can. Hi Devang, good to see you. Long time. Dr. Manan, good to see you. Yes. So, any other questions? Please feel free. Dr. Viraj, hello. Dr. Riddhi, some questions from you. So let's see if we can churn up some very interesting discussion. So I have got another how to deal with totality arising from rapid weather transits. Okay. And Dr. Naisargi, when to use intercurrent medicine? Okay, I will take up the first one, how to deal with totality arising from rapid weather transit. So always the effect of the cause. If weather transitions is the cause, the effect, always the effect in homeopathy is more important than the cause per se. But that does not mean that you ignore the cause. I would prefer to choose a remedy which will cover the effect of that weather transition as well as the causation. So you will also have to consider what kind of weather transition. That will be important to figure out. Either it is from monsoon to winter, or from summer to winter, or winter to summer. That becomes important because every remedy, every constitution has their own sensitivity. So, first, obviously, will be the effect. If you can find any characteristics in the effect, and then the cause. And if you cannot find, sometimes it can be like that. So I give you one case. I just got this yesterday. It was very interesting how I approached this case. So this patient of mine is in Canada and he calls me up saying that I have a very severe head cold after we went out for an outing and we were not prepared for the weather to change. And suddenly the weather became very chilled. I had no cap. He's already bald. And then in 3 or 4 days, he says, I came down with a left sided headache. So, if you look at it, I said, any other modalities, any other changes that you have got? He says, no. No modalities, no concomitant, no change in thirst, no change in appetite. So, how do I deal with this case? So, I said, and of course, for a lot of you would know that I work very extensively with the therapeutic pocketbook. And I would love to show you how I worked out this case. Dr. Keyur, is there any possibility I can share my screen on this live this? It would be very interesting. Just tell me if yes, and is there a way? If not, I will tell you and you can see I open the polarity analysis software. I said aggravation from becoming cold or getting cold. Okay, and left sided. And I took left sided complaint and I took inner head. That is where the affection was. And the remedy that strikingly was arsenic. Simple remedy, straightforward prescription, and I gave arsenic. And I told him report after 12 days, 12 hours, and he said I'm 90% better with this. So this is one of the examples how I would deal with it. In this case, not too many characteristics. In fact, hardly any except the left-sided location. So I took general left side. Then I took aggravation, cold becoming, and head is what I took the location. So he did very well on arsenic in just one dose within 12 hours, and he was quite a bit in pain. So in fact, he called me up and said, "I'm so much in pain. If you can do something immediately, I would be very happy." So I hope that takes the uh, question. Then of intercurrent remedies, the idea is I don't name medicines. Intercurrent, constitutional, acute, phase remedy, state remedy. Bhagwan jane how many names we have given. The idea is straight and simple. Instead of getting lost in the jargon, what is the totality at that particular moment in time is important. The challenge to the homeopath lies in identifying the totality in that particular moment in time for that patient. So I will support it with another case example, and I believe that it will, in fact, I will give you two case examples and you will see how things shift. So there was this young boy with ulcerative colitis, and to whom I struggled really hard for a year before I could really make a dent in this case. And he would only bleed in his stool, only bleed. He had exhausted all the allopathic medications, nothing was helping. He was just probably 10 or 12 when he came to me, and he would bleed. The first remedy that really made any dent in the case and which helped him for a year was gallic acid. We will not discuss how I arrived at gallic acid. And for a year he did wonderfully well. And then what happened was he had a bout of exacerbation. Okay? And he was bleeding profusely from the rectum. And I reconsidered the case. His state of being had changed, and some new state of being emerged, which indicated phosphorus to me. And all along this time, for almost a year and a half that I treated him, he would just tell me bleeding in the stool. No other modalities at the level of the disease. Nothing. No modality, no characteristic. I would ask him any change in thirst, nothing. Change in mood, nothing. And the only thing that I was left with was to prescribe on his state of mental disposition. Now, after giving phosphorus for another 3 or 4 months, suddenly phosphorus also stopped acting and he was bleeding like a tap. Literally frightful bleeding, half a tumbler of blood every time he went. And I'm not exaggerating one bit of this. And I had to do something really urgently. I changed phosphorus in different potencies, nothing happened. I retook his case and I really didn't find any change in the state of being on which I had prescribed phosphorus. And I had to think now something out of the box. And then I look back at my struggle of finding the remedy and why the remedy is not holding. 3, 4, 5 remedies not holding. And a young boy with ulcerative colitis, a serious autoimmune disease, which can completely be very fatal and it can completely severely compromise state of life, quality of life. Now here, that struck me was he is unable to heal himself. The remedies work and stop working. This became my first indication. The current state was his inability to heal and inability to throw up characteristic symptoms at the disease level, which I expect a 12-year-old boy would do. The third I took was hemorrhage, profuse hemorrhage, bright red hemorrhage, and an autoimmune disease. This became my totality for that moment in time. And the only remedy that ran through this in the best possible way, as to the best of my knowledge, with the inability to react and reaction poor, was my rubric. I took tuberculinum as the remedy and I gave him tuberculinum. And this tuberculinum immediately stopped his bleeding. For 3 or 4 months, tuberculinum helped him really well. Then again, the twist happened. And then you will understand what is lack of reaction. After 3 months of tuberculinum, he again started bleeding like a tap. And giving tuberculinum did not help him. But something twisted, something changed in the case. Now, with the modalities that he had come, he came up with very characteristic modality of the stool and the bleeding. First time in the whole history came up characteristic at the disease level. So I said, now if a homeopath has characteristic symptom, he can conquer the world. And I just took down those characteristic symptoms, put them in the therapeutic pocketbook, once again my favorite repertory. And lo and behold, the only remedy that got indicated with the highest mark was phosphorus. And I gave phosphorus and the bleeding stopped immediately. In fact, for the next 2 years, only phosphorus helped. So, Dr. Naisargi, if you understand, one would like to call it intercurrent prescription. I call it indicated remedy. The idea is, what is curable in the disease, aphorism number 3, at that particular point in time, that is critical for the homeopathic physician to identify. If you miss that identification, then you miss the boat. The other case I tell you was this girl with huge alopecia, big hair loss, young girl, 8 years, 9-year-old girl. She was given all allopathic medication, all immunosuppressors, nothing helped her. And she was referred to me by one of the dermatologists. So the most prominent part of the case was too much suppression is happening and lack of reaction and alopecia. And this was an autoimmune alopecia as diagnosed by the dermatologist. So this became my totality. And once again, here at the very beginning of the case, I gave tuberculinum and I didn't need any other remedy to completely take care of this alopecia. So the whole idea is, what is the totality at that particular point in time for that particular patient? That is what I identify. And with practice, you learn to do it well. And I don't hesitate too much to change the totality with the changing movement in the case. 10 years ago, I would be very hesitant. You have chosen the constitutional. Now this is the panacea and it has to take care of the whole case. I have long back now given up that idea. And things move more faster for me and more easier for me. It's not a burden, which earlier it used to be. So I hope that clarifies some degree of this idea of intercurrent. The idea of, in the earlier case, that was the intercurrent. The idea between the two remedies, you posed it, and that helped to actually bring back the reaction and the characteristic which were missing. So that was intercurrent, if you like to call it. You will call a particular remedy only retrospectively, not beforehand. Dr. Devangi, welcome. Good to see you. Yes, on management of tinea. Now, I will last year, in fact, during the COVID time, we had this discussion with my colleagues. We were four or five of us, and incidentally, something happened about tinea, and I said, now I'm getting consistent results when I take the exact acute symptoms of the tinea and prescribe for it, and I'm able to consistently get results. Another colleague comes and tells me, look, I have given constitutional remedy and she has done wonderfully well. The third colleague comes and tells, look, I was struggling with this case and I gave the intercurrent remedy or the anti-miasmatic remedy and she did well. So what we all did was we poured all our cases and we tried to examine what we have done. Interestingly, well, I was the one who said take the local symptoms. And then when I look back into many of the tinea cases which I had treated quite successfully, I had had quite a few cases which I had treated with constitutional remedy. So we had three different ways of treating tinea and we examined the cases quite carefully and we had some semblance of what to do with tinea. Is you have three settings. One setting is this very acute itching and everything is red and unbearable. So what if that stands out in the case, Dr. Devangi? Take up those symptoms, treat the patient, give the remedy that gets indicated then. In situation where tinea has been very old, it's there, but it's not really bothering, or it bothers a very little bit time. At that time, we also found either it can be the constitutional remedy that can help, or the anti-miasmatic remedy that can help, considering the myelin. So a rough estimate, we found that we could make up this kind of algorithm about treating tinea. I don't know what is your experience. Maybe you want to share it. You want to put it up on the chat box. It would be very interesting. Dr. Shabina, I've already answered the case, answered your question. Any other? I hope, uh, Dr. Devangi, does this answer satisfy you? So I think what I have learned over these last few years is sometimes instead of determining the approach preemptively, you wait and see how the case is going to is presenting to you. Many times, what is standing out and dominating the whole case will need to be addressed first. Till that is not addressed, it's not going to work. So till I get another question, I will also get back to this Dr. Shabina's and Dr. Naisargi's question. So I had this type 1 diabetes girl, 20-year-old, and she was freshly diagnosed with type 1 diabetes. It's a little late to diagnose type 1 diabetes, but that was what it was. And she said, I want to do homeopathy. I'm taking insulin. I want to get rid of insulin. I said, let's see what best I can do for you. And I took the routine case, gave her the constitutional remedy, and the diabetologist with whom I work, after giving the constitutional remedy, she says, this is wonderful because there is in type 1 diabetes, the blood sugar levels are very erratically fluctuating. But in this case, she has stabilized. So I achieved what I talked about, the glycemic variability, dampening the glycemic variability, I could achieve that with the constitutional remedy. But I said, let's see if I can give her something better. And I redid her case. And by the time I had studied this science called evolutionary medicine deals exactly like our theory of chronic disease to find the fundamental cause of diseases. And when they studied type 1 diabetes, they found very interesting correlations between tuberculosis and leprosy. What was the correlation? Uh, in situations in world areas where leprosy and tuberculosis were disappearing, there was a spike in the cases of type 1 diabetes. This was quite proven. So, in a way, there was a causal association between the incidence and the prevalence of tuberculosis and leprosy vis-a-vis the prevalence and incidence of diabetes type 1. So, using this wisdom, I redid her history, and in the history, I gave great importance to understand more deeply the family history of this girl. And almost toward the end of the interview, the father was almost shy telling this. He said that I had tuberculosis and I took treatment for 9 months for it. And then I gave her tuberculinum bovinum. And after giving tuberculinum bovinum, I found when before we started, she was on 4 and 4, 8 units of insulin, and we could bring it down with her sugars going further down to just 4 units or 3 units in the whole day. And this was something very striking for me. So, again, what is the totality in that particular time for that particular patient? That is to be identified quite correctly. Yes. Yes, Dr. Devangi, I agree with you. I also struggle with tinea quite a bit. Incidence of what, Dr. Shabina, to COVID? Thank you, Dr. Devangi. Dr. Shabina, what is your question? Relationship between DM leprosy, DM type 1. Be very careful. Be very careful about this. DM type 1 and DM type 2 are two completely different disorders. And they behave completely differently. The factors that influence their course are also very different. So, DM type 1 leprosy, COVID is what they say, and we need to wait for more research to be published. Because now I believe what is happening is now the politics behind the vaccine and COVID is slowly fading out, and some real picture is really coming up. Which case, Dr. Devangi? Sorry, Devangini. I always keep making this mistake. If you can share a case highlight, okay. I don't remember off my sleeve, Dr. Devangini. It will take me some time to pull out that case, but I will try and do that. Maybe some other time. Yes, but I will tell you, Dr. Dhara. Dr. Devangini, I tell you that especially in acute uh, tinea, where it's very severe itching, I have found a therapeutic pocketbook very consistently helping me. Very consistently. Okay, which repertories do you prefer? Do you use different repertories for different types of cases? If yes, Would you please elaborate how you decide? Yeah, this is very interesting question, Dr. Dhara. Very, very interesting and very important question. Not just interesting, but it is very pertinent. What is very important is I treat repertory like a tool. So, like for a surgeon who has 100 different toolkit when he has to operate, and for different surgeries you have a different set of toolkits. Some tools are of course common, but some are specialized for that surgery. So my repertory is also, in fact, when I did the Fatak repertory series just very recently, that is exactly what I had discussed, that every repertory is a tool, and what you will have to find the niche for that tool. That means this particular repertory is useful in which kind of totality. Please note my wording, which kind of totality, not which kind of cases, which kind of totality. Why I say this is because if I say, look, Fatak repertory is great for diabetes cases, then we all will start looking at Fatak repertory for diabetes cases. No, that's not the situation. A diabetes case where mental symptoms and mental stress are very prominent, in that case, maybe the synthesis repertory is useful, maybe the kingdom classification is useful. But a diabetes case where a complication is very outstanding, like I tell you this case of this very old man with many years of diabetes, and he had developed phimosis and a very bad balanoposthitis in spite of his insulin and OHs, everything was going on. So I gave the constitutional remedy, not helping him with that. So what I did is I took the local symptoms of the balanoposthitis, and I found that this local symptom has lot of nice modalities, very good modalities. They were all common modalities to the disease, but good, prominent, clear, undoubted modalities. So when the modality stands out in my totality, the best repertory of choice is therapeutic pocketbook. When a pathological general stands out in the case, then the Fatak repertory or the bogus supplementary repertory or the bogus repertory with the synoptic key or bogus card become very useful. If the delusion stands out very strongly, then maybe synthesis is very good. Or maybe the kingdom classification of Dr. Shankaran is very good as a tool. And if you have just two characteristic symptoms, regardless of whatever is the symptom kind, then my favorite repertory would be Fata. Because that's most apt when you have just one or two characteristic in the case. But if you have five characteristic symptoms in the case, using Fatak's repertory in an unskilled way would be a disaster. So I asked three questions. Which kind of symptoms does this repertory represent well? This is first question. So you study that. Then you check how are the remedies added. For example, if you take a remedy like synthesis, you will find every symptom is added of the repertory in the repertory. Every symptom of the remedy is added in the repertory. In contrast to that, if you look, Fatak's repertory only selected remedies and selected group of drugs. Sorry, selected group of symptoms of that drug, which the author has chosen. So you have to be in line of that author and think why he has chosen only these symptoms of this particular remedy. So there is a logic behind it. If you align yourself with that logic, then you will be able to pick out that particular case that particular totality for that particular remedy. This is very important. So, and the third question that you will ask is, what is the structure of this repertory? Phatak made it simple, straight, but there are nuances in the structure. Like the therapeutic pocketbook has generalized everything in the most homogeneous manner. Means every rubric is generalized. Every symptom is generalized, so there is no other question to look anywhere else. In Phatak and in Boger, they have also generalized, but some selected symptoms. The other symptoms, they have kept it as they are in the materia medica and in the proving. Now, these are subtle nuances that you will have to study. And then you choose which totality and which repertory match together. So, I hope some light on this, Dr. Dhara. So, once again, I reiterate which type of cases and which type of repertory, don't do the correlation. What kind of totality and what kind of repertory works better for a homeopath? If pure diagnosis are there, pure diagnosis, only diagnosis. So recently I had this case with premature precocity of this girl, 9-year-old girl with breast development, pubic hair development, axillary hair development, and changes in moods like a teenager. And the mother was a doctor, extremely worried. And then we looked at the whole details of the case, and we wouldn't get anything characteristic except changes in the mood, nothing more, development of secondary sexual characters. And what was the cause of this? Nothing. Now, what do? The disease itself becomes characteristic, if you understand, Dr. Dhara, especially for you. The disease itself is so rare that it itself stands out. My old assistant also said, "Sir, we want to come and see this case. This is once in a lifetime case. This is rare." So I directly took this as the symptom, as the eliminating symptom. And I had probably 6 or 8 remedies from synthesis. There is, of course, this rubric is there in Phatak also and in Kent also. And the best possible choice that I could do was suprarenal gland, because nothing more was there. And if you understand the pathology of the sexual precocity, you will find first it is the adrenarche that happens, and then the menarche. That means the adrenal gland starts functioning precociously, and then the actual genital sphere. So here, in my totality, the disease itself is peculiar and individualizing, and I will choose a repertory which will represent this best. So which repertories represent the disease best? So we have 3 fantastic repertories. One repertory is synthesis, which is very, very comprehensive. 2, you have Clark's repertory. Do not miss out Clark's repertory when you are faced in a case like this. Third is Boric and Boric therapeutic index. And fourth is Phatak. I had shared this case in the webinar series of my colleague Dr. Vinayak Patkar, where he was faced with a child with birth asphyxia. And he used this rubric asphyxia neonatorum, and he chose the remedy. What was the remedy? Lorosericious, I think. Yeah. And the child got completely well. So again, Phatak was useful because disease name and you pick up that. Okay, so I think I have answered this question quite comprehensively. We will take up 1 or 2 more questions before we depart and come back after some more weeks. So someone has asked about your experience with synthesis repertory. My repertory with experience with synthesis repertory has been very good. So this I take this opportunity to generalize this question and ask myself whenever I'm faced with a new repertory, how do I say that this repertory is good or this repertory is worth giving my time to? And Dr. Devang is here. I don't know if he's still there. And we just had this discussion that everybody comes up, no, one new repertory in the market, and we all flock to it and say it's good or not. So what I do is I benchmark all the repertories. May it be Fatak, may it be Kent, may it be BBCR, may it be the bogus repertory, the bogus card, with the therapeutic pocketbook. You remember in physics when we were studying in 12th standard, they would say that in the Paris Museum, they have kept one platinum iridium rod of a particular length and they call that as 1 meter. That is the standard 1 meter. They will compare every other scale to that Paris benchmark. So we need a benchmark in our repertories also. Why did they choose platinum and iridium? Because the platinum iridium alloy is resistant to any form of weather changes, any form of disturbances. It's so noble. So same way in homeopathic literature, I had to ask, which is that platinum iridium alloy? Which is that benchmark that I can really weigh all the repertories against? And I found the therapeutic pocketbook. Why? Because the therapeutic pocketbook is not only factually so accurate in the symptom content, that means symptom wise, if you study the remedies, the error rate, note this down, the error rate of therapeutic pocketbook was found to be 0.001. That means over 1,000 entries, one mistake. No contemporary repertory matches this level of accuracy in terms of content correction. The second part, why therapeutic pocketbook becomes the platinum iridium alloy for us, is not only it represents the remedy symptoms exactly, but it represents, because of its structure, the whole portrait. If you pick up the portrait of platinum and study the platinum portrait from therapeutic pocketbook, exact minimum distortion. And this is where contemporary repertories find it very tough, especially the Kantian kind of repertories. The distortion between the exact proving portrait and what gets pulled out from the repertory is quite different. And how does this happen? Is the gradations. So if you read Bonninghausen's introduction, he says that I have taken so much care in grading the symptom that if at all the error is going to be only of half an interval. So if he has graded 2, then the error could be this symptom is 1.5 grade or 2.5 grade. Not even 1 grade difference. And this is where all the Kantian kind of repertories find it very difficult to match this accuracy. Because remember, you need this accuracy. We are going to match portrait to portrait, not symptom to symptom. Remember, in homeopathy, you have to match two portraits, not just symptoms. You have to match the portrait through the symptom. And therapeutic pocketbook, most successfully with minimum distortion, has the ability to bring this proving portrait into the repertory with minimal distortion whatsoever. And therefore, Bonninghausen in his preface phase, on the first page, he will write, it is not only a repertory for the use at the bedside, but also to study the materia medica pura. No other repertory can boast of this. Though there are 126 remedies, it's the gold standard. Therefore, all the new repertories or any repertory, I will put the case, solve from two, from the therapeutic pocketbook and for this, and then check the results. And with synthesis, with Murphy, I found very consistently both of them almost near equal cases where I find they almost emulate therapeutic pocketbook cases. So I hope I've been able to share quite a bit of things. So we will take a pause now for today. And okay, last question, Dr. Parik's homeopathy. How much time should you wait to see results in type of cases, especially of diabetes mellitus? Dr. Parik, very, very big question. First thing, diabetes itself is a very big question. Big disease, big spectrum of disease. It's no more a disease, a individual entity, stable entity. It's a very fluid entity. You have a spectrum. And depending upon where your spectrum are, out of, you remember I talked in the beginning of the glycemic pentad, five things: fasting sugar, post lunch sugar, HbA1c, glycemic variability, and quality of life. So depending on where you are on the spectrum of the disease, you will determine what you can achieve. Like I told you, this old man's case with melanoposthitis, with a handful of OHAs and insulin, I am not dreaming for him to cure him and bring down his insulin also. I am here to look at his quality of life. At 80 years old, he is able to have sex with his wife. Wonderful quality of life, nothing better. What you say, Dr. Parikh? Good, no? Most people have given up by the age they reach 50. So how long should you wait? I have seen, if if the remedy is good, then within 2 to 3 weeks you will see the sugars plummeting. In fact,
it's 4 o'clock.
Okay, so thank you so much for wonderful questions. We'll come back after some more weeks and we will keep sharing our thoughts and processes. So, goodbye, Dr. Keyur. We will stop for today. This session will get uploaded. Maybe those who want to see it for a later time, welcome to see it. And we will keep interacting. Please write your queries in the comments, even later ones. Let's see how much I will be able to answer, because there are a lot of things that I wouldn't even know. So, goodbye. Take care. Bye bye. I'm ending the stream for the moment.